How are you doing? Yes. Can you hear me okay? I can't hear you. How are you doing? Can you hear me? Okay, your cameras, you should be hearing. Are you hearing me? Because your microphone.
Yes, I
Oh,
can.
okay. Okay, your microphone's connected. I was wondering what happened. So
So, is my voice okay?
yeah, the background looks good. Uh, y- you know, uh, I'm arranging for that webcast with the AI guy from Germany. He sounds like a really good source of information.
Yeah, that's the same person I spoke to. Kind of.
Yeah, well, anyways, I was looking up the archive of radiology webcasts we've had over the years because we've had a good number. And we had one of the exact same title that he did one on, value-based radiology. And we did a Google Hangout, not a Zoom. Did you ever use a Hangout? It was a video platform. Did you ever use that?
Hmm.
Do you know what it is? Google Hangout?
No, never used it.
It's like Meet, but it's more. It's got more features like Zoom, but they don't really push it anymore. We used that before Zoom, and I'll send you the URL of what we did 9 years ago.
Hmm.
9 years ago. So
Oh,
these are contacts that are going to help me put shows together
mhm.
because when I contacted him, I said, "Hey, why don't you come as a panelist? It's the same topic. You did a webcast for me 9 years ago."
Yeah, that's.
Yeah, I didn't notice. I didn't realize that. But with most speakers, I have some connection with I have like 3,000 videos archived.
Hmm.
That's a lot of webinars.
Hmm.
It doesn't sound like a lot, but it's a lot.
So, is Victor coming?
I'm sorry.
Is Victor coming today?
Oh no, no, no.
Is he busy?
I don't know who I posted it on social media. Did you get contact anybody for like a host or anything, or you're not using anybody?
Sorry, your voice is not clear. Is my
Yeah,
voice
yeah,
better?
we got a few minutes. See if you can rustle up a host. We got a couple of people coming. Oh, Fitri's here,
Is he?
but she's not a neurosurgeon. She's an anesthesiologist. Yeah,
Yeah, Fitri attends every lecture. We are thankful for her active participation.
okay, I'll be back in a few minutes. Okay. Well, you know, the weekend,
Hello.
Yes, hello. Hi.
Yes, sir.
Hi,
How you?
Suresh. Do you want to
Yes,
come in?
Suresh.
Hi, you want to come in the panel?
Okay, I'll try to do that. Maybe another 15 minutes.
Okay, well, I'll try to promote you now.
Okay, you start the webinar. I'm there on the,
Oh,
I
okay,
see
yeah,
audio.
we
Oh,
start in 6 minutes.
oh, sure. Please start. Dr. Bhatti should start, please.
Okay, no, 6 minutes. 6 minutes. Fitri, you coming in?
No.
I'm listening.
Where are
I'm
you, Fitri?
listening. I'm,
Fitri, don't cause any trouble.
yes, yes. I'm
Don't,
listening.
don't cause any trouble, Fitri.
Yeah, yeah.
Hi.
Yeah, Fitri's
Hello, Nata.
Fitri's
Hello.
an
I'm listening. I'm listening.
anesthesiologist. She's an
Yeah, yeah.
anesthesiologist from Indonesia.
Yeah, I'm from Indonesia.
Yeah.
I'm listening. I'm listening.
Yeah.
Have you been traveling, Fitri?
No, no. Yeah, a little bit, John. Maybe tomorrow.
Conferences?
Yeah, yeah. Maybe Wi-Fi. Wi-Fi is not good.
Oh, where you're at? What city you in?
Hmm?
The Wi-Fi is not good now?
Yeah. No. It's good.
No, it's
It's
okay,
not
yeah.
good. You see, it's my maybe about the battery, about the batteries.
Could be. Could be. So Atta, we'll talk to the students about the weekend, the time. It was 7 and 8 o'clock, but it's not written in stone. We could always change it.
Okay.
But this week I couldn't because I have a webinar on neuroradiology. I don't know if you're interested in that. We have it, it's in English from Spain tomorrow at 8 o'clock Eastern time. Let's see, it's 2 o'clock, 2 o'clock CET tomorrow,
Mm-hmm.
if you want to come to it.
It's Louis. Is it Louis lecture, John?
Yeah, Laura, you can, yeah, come in tomorrow morning. Hey, let me show you. Let me send you the link.
No,
Yeah,
no, no.
Laura,
I had registered. I already
oh,
registered.
okay, because, yeah, he has all of he had Vlad, he had Richard Hanel, who you may have met in Spain, and he tried Demetrius. He couldn't get Demetrius, but he's doing it with the old crowd he had before that had that conference in Spain. So that's where I started really meeting people. And I went to a conference. You know, I tried to get neurosurgeons to interview people with their smartphone, but most of them didn't feel comfortable. They I just said, just take your smartphone out, talk to the guy that just spoke, right, as he's coming off the stage, and say, could you step in the lobby? We want to interview you with neurosurgical TV. And because you can interview very effectively with the smartphone. It's a
Yeah.
good camera. You
Yeah.
use the camera and you put the audio on, and it's like, it's a good shot. It's good audio because most of these places have good Wi-Fi because it's a conference. But no, I haven't got anybody that's crazy enough to do that or adventuresome enough. Yeah, we have a couple of webinars on. We have one in Spanish. I guess You don't speak Spanish, right? From Argentina, we have that on Wednesdays.
In French.
Wednesday, yeah, on neuroradiology.
In French.
No, in Spanish.
Mhm.
Spanish, yeah.
So please
You
do let
want-
me know if you have anything in French.
Oh, you speak French.
Yeah. Je parle.
Oh, great. We have a French channel.
What? I'm
Let me show
I'm
you.
I'm a learner. Yes.
Oh, you're learning.
Yes.
Hello, Ivan.
Hello, how are you?
Good. I'm John Bennett. We run this. My co-host is Ata Bhatti. He's also presenting today.
Nice to meet you.
Where you from, Iman?
I would speak with you. I'm from Libya.
Oh,
We
great,
have
great.
chatted
That's right. I did
together
meet you before.
on WhatsApp. Yes,
Ata, he's a rare guy from Libya.
but
We don't have many
it's
Libyans come.
yeah, it's been a long time. I didn't attend the meeting.
Okay, we're always ready to do a Libya Grand Rounds if you have a group, you know.
Yeah,
Uh,
God willing. I hope that
well, if you do, if you
I'm
meet
trying
some
now
other,
connecting.
yeah, if you run into Libyan neurosurgeons, just present a case, interesting case. It'll be easy. You know, get 2 or 3
Yeah,
Libyans and we'll do a webcast, Libya Grand Rounds. That's
I
how
will,
we do it, Ada. Hey, I hit
yeah,
everybody.
I will tell all Libyan residents and the neurosurgeons. I will
No,
try
no,
to
it can
make
be
a group
no,
and
it can be
invite.
attendings also, it can be students, it can be residents. So anyone in the neurosurgical community in Libya is welcome to come.
Thanks a
Even
lot.
nurses. Fitri here is, she likes this platform. She's from Indonesia. She's an anesthesiologist.
Yeah, the
Hi,
only one.
good to
You
see
know,
you.
Good to see you.
you
Yeah,
know,
good to
Fitri,
see you. Good to see you.
Thanks a lot.
you know, Fitri, we had an anesthesiology grand rounds with Stanford for a while. We had a radiologist from Stanford doing it. Because you get people in every specialty that really like this
Yes,
platform. But
it's like multidisciplinary team or something like that.
yeah, well, I'm
Yeah,
just trying to harness it in a bigger way because I don't think it's really seen its potential yet. I think once we get organized, like for example, today I was trying to arrange a webcast. He had this doctor from Germany had someone in the same field I did a webcast for 9 years ago, not in the same exact title of what he did 9 years ago. So it's going to
yeah,
be interesting to find out the difference in the 9 years since one radiologist was at the forefront and now there's another radiologist doing all the new stuff, which that's going to be interesting, Ada, to hear about the new stuff
yeah.
in
It's very
radiology.
interesting.
Well, you got to have the radiologist has to keep up with the tech because if they don't, they're going to hire a radiologist that does the AI. They got to know AI. They gotta. Otherwise, they won't get hired.
Mhm.
That's a sad reality, Fitri.
Yeah,
Yeah. You talk to any radiologist,
yes.
they could see it coming years ago, I think.
Yeah.
I think that they've been preparing for it. So uh, something that's going to affect them so deeply.
Mm-hmm.
It's okay. I don't have 14. That's good.
Is
Oh,
as
good. Dr.
Ayman is a radiologist or neurosurgeon?
I'm a neurosurgeon resident
Oh,
in Libya. Yeah,
From
good to
Libya.
see you.
You won't
yeah.
From
you
Libya.
won't meet many neurosurgeons from Libya.
Yeah.
Yeah, yeah.
They're there. We just need to connect them.
Yeah.
Yes.
And Libya,
Yes.
I almost went to visit Libya. A friend was doing business actually with Gaddafi, a friend of mine. Yeah, they were partners in apartments. Well, guess what happened to his
Yeah.
money?
You are most welcome.
No, I
It
know.
will be a great chance.
I know he lost everything over there. Anyways, we're ready to start, Ata?
Yes, sure.
Okay. Let me make sure it's all set up on YouTube.
John, Byrne and Halim are there. So can we take them in panel? Dr. Byrne Dobler and Halim, if it's okay.
I'm sorry, Ata, someone in the panel that I'm not letting in?
Dr. Byrne Dobler and
Oh, yeah, okay.
Halim.
Yeah, no worry, I'll get him in.
Dr. Halim, this
Yeah, I invited Dobler. Okay, Bernd Dobler, yeah.
and
I'm
Halim.
I'm glad he came. I was going to remind you.
Halim.
And Amy Gold, Ali. Do you see his name there? I don't see his name.
Yes.
Amy Gold
Hi,
and
I'm already here. Thank you.
Okay.
Olivia.
Okay, great.
Oh, I don't see Olivia. Is he in yet?
Halim is here, yes.
Oh, he's here.
Yes.
Oh, okay, we can start. Okay, here we go. 10, 9, 8, 7. Hold on. Oh, I got it. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good afternoon. This is Dr. John Bennett broadcasting from the shores of the Atlantic and Miami Beach, home of Neurosurgical TV. We have the pleasure of having Atta Bhatti, a dual neurosurgeon. He's currently in Geneva running an organization, Neuro Healthcare for LMIC. This is a regular broadcast every Tuesday. And Atta's going to be talking about what he does. And today, he's going to speak about basically the importance of knowing embryology and neurovascular surgery, as well as other things. Welcome, Atta. It's all yours.
Thank you, John. Can you see my,
Not yet.
okay,
You haven't started.
now?
The share button, you got to click first. Share.
No?
Yeah, not yet.
Not yet. Oh, okay.
You'll get it. You'll get it.
I'm there?
Not yet. You got to click the share button. You're not clicking the share button. I can tell. There you go. Okay. Now work on it.
No?
Okay. Now full screen, please. Presentation mode at the bottom. One of the icons at the very bottom. Very bottom. One of those icons.
Yes.
Perfect. Perfect.
Thank you so much for all the attendance and John. And we will continue with the exciting journey of neuroembryology. Learning embryology is becoming safe in neurovascular practice. And as we know that embryology explains us many concepts about the variations, and we do not need to memorize different variations and anomalies. It helps in interpretation of DSA. It also makes a more meaningful interpretation of operative risks and complications by analysis of difficult situations. So today we will revisit vascular development in human embryo. There is a lot of repetition. We are trying to consolidate our basic terminology, since neuroembryology is not day in, day out topic for neurosurgeons. We are trying to just build our base and foundation, and we keep repeating things. Today we revisit some of the concepts we did last week. Also, we try to connect it more clearly to the developing different stages. We want to go into the more specific names and classifications of the stages, but we go with the size to understand what things are going on. It's showing that how the embryonic, fetal, and initial fertilization conception phase shows the development of different segments, different organs. So the pre-embryonic stage is from the conceptions, and there are a lot of difficulties to estimate those age. By the time we pick the pregnancy, it's already 1 week or so. That brings in different ages of the embryos. So as we see that in growing embryo, in the most initial stages, in the pre-embryonic time, if something happens wrong, it gets the loss of that pregnancy. It's a nature's way of taking care of major anomalies. But still, in the embryonic development, which is from 3rd week to 8th week, if there is major abnormalities happens, if there is any trigger in the initial phases. So the first organ which happens to be present in the embryonic phase is heart. Although the neural tube and neural foldings and the trigeminal and trilaminar and bilaminar plates formation of the stem cells of the growing embryo after the implantation, the growth which leads to the duplication, doubling, then a lot of processes involved in which we see a lot of folding, vaginations, cavitations, condensations, dispersion of cell groups, and formation of complex organ eventually materializes in the embryonic phase. This is the most dynamic, most vital, from the 3rd week to the 7th week. And by the 8th weeks, you have almost adult-like neurovascular and main organ formation. As shown, the neural CNS development keeps going even in the fetal period, and in postnatal period also there is more maturation of the central nervous system. Heart completes by the mid of embryonic 6th week, and we see a very human-like upper limb, lower limb, ear, eye by the end of 6th, 7th, and 8th week of embryonic development. So there is a lot of dynamic activities, starts from the ventral of the embryo, growing embryo, and it is the heart which shows first the islands of different vascular legs, like angiogenetic process, and then different formation of different paired arches, which we called aortic arches from the pharyngeal apparatus, which we discussed last time. So in order to guarantee the integration of the assembly, the process going on in the different region of the embryo, and simultaneously there are many dynamic changes, and this space and time is different for multiple sites, and there are coherent process, very foolproof, and this is all is called as morphogenesis. This is highly regulated, and there are a lot of chemicals involved to regulate it, and these are very important in terms of giving the right cue to the progenitor cells to form the right product, and there is a lot of feeding information through these and the neural tube and the neural tissues itself secretes those, and placenta initially is a source of those chemicals which regulates this. So going back little bit to the history, as we know that there are Carnegie classification, and the credit goes to the Streeter, Paget, and Cogton. So Paget has continued basically the work of Streeter, who was a embryologist. In 1948. There was a there was Paget's written neurovascular neuroembryology paper was considered as the gold standard reference, and it still is. It's a key morphological steps for head and neck development. So that cerebral arterial system, starting from the as early as 3 weeks, when the embryo is 3 millimeter in size, and it describes beautifully all the weeks and all the sizes till the very human-like neurovascular embryonic system. So it's mandatory to mention E.D. Congdon, who in 1922 uh, gave into the description of embryology of aortic arches, which are very relative to the discussion going to the next stage of head and neck vascular formation. So aortic uh, arches are the sources of the tube formation, and uh, regression and connections leads to the adult-like neurovascular tree formation. So, of course, Pierre Lesdonias, who is having the very high impact leader, he was a neuroanatomist, cerebrovascular anatomy, embryo and comparative anatomy work done by him and published very extensively, became a must read and must understand for all the neurovascular and neuroendovascular. He had an extensive angiography related patient pool, and he compared embryological hypothesis with the physiological developments, and in pediatrics as well as in adults. There were very uh, essential contribution of him in the field of vein of Galen malformations, uh, the peri-arterial neoangiogenesis, and things like. So Streeter gave the 5 steps to the formation of vascular system in the human embryo. And he described it at that time in 1920s as angioblastic stage, then artery, venous, and capillary formation, penetration of perforators and more large vessels from the web, and histological differentiations. So this was excellent work in the era when microscope was not available, and this gives a detailed description of the uh, basics, and to just reinforce that vascular T formation in an embryo uh, comes with the influence of various factors. There are segmental specificities, segmental identity, which Pierre Lesdonias labeled as vulnerability, growth, annexation, regression, stem formations, then branchings, some disappearances, some new vessel formations, some new flow hemodynamic, but that all process was regulated by the demand and supply of the growing tissue, and there are the stages of vascular development, which are the dynamic process starting from the embryo in the form of angiogenesis, and later it becomes continue in the form of vasculogenesis as the daily wear and tear processes leads to the remodeling in health and in disease status, and leading to the ever changing dynamics of the vascular tree. So recently the stem cell and other work in the form of different models bring in the rapid strides in the field of human development and stem cell technologies. It had enormous, tremendous advance, and this made us understanding of human embryogenesis far easier than it was before. To see a human embryo growing in a real time like things, uh, leading to the landmark models and studies and making the gastulation, organogenesis and hematopoiesis like processes recapitulated during the embryonic dynamic phases. So to review this concept of gastulation, in which the fully intact human embryo at the time of 15 to 17 days of post-fertilization or Carnegie stage 7 uh, forms the three plate or three germ layers, and which leads to the formation of neural tube after pitting, and then tube formation, neural tube formation, and then there are that mesodermal derivatives of neural tube leads to uh, the dynamic process of cavity formation, initially the 3 cavity formation and then 5 cavity formations in the form of prosencephalon, mesencephalon, and metencephalons. So prosencephalons further divides into telencephalon and diencephalon, and the mesencephalon or the midbrain is the initial structure in the form of C-like flexure. There are different folding, and when the forebrain develops, the foldings will become more straightening, and the neck becomes more extended or neutral in position. So that all process of organogenesis happens in the in vitro heart forming organoids, and recapitulation of these through the new techniques makes the field more exciting and more dynamic. So this seems as a process where the 3 divisions, 5 or 6 subdivisions formation happens. So as we see, prosencephalon has 2 components: telencephalon or cerebral hemispheres, and then diencephalons, thalamus, hypothalamus, epithalamus, and mesencephalon, the midbrain, and the rhombencephalon in the form of metencephalon and miencephalon. In this diagram, you see this 3 cavities in the form of embryo at the 23rd stage or at the end of the embryonic stage uh, of the pregnancy. So we see the mesencephalon in the posterior at the junction of rhombencephalon and the telencephalon. In the bluish, we see the diencephalonic structures, which are later discussed. So here, through the help of ultrasound, we can measure the dimensions. So this is where the crown rump length happens to be useful for the measurement of this growing embryo. We see the umbilical cord. The placenta is not visible here. We see the ear as a demarcation eye, which looks like human, although it's laterally placed. Heart is seen very clearly. So there are a lot of human-like limb formation, especially the proximal arm and proximal limb, and eyes, nose, and facial structures are much clearer here. So the cerebral hemisphere formation is a process which starts earlier, and it keeps on growing from the embryonic phase. At the end of the embryonic phase, when telencephalon is quite grown up, to the 3rd month, where the formation of different lobular structures, and then the insula, future insula overrides in the activity to form the more more prominent diencephalic and neopallial prosencephalon, telencephalon part growth, and this is how the neuronal growth happens. I would like to mention the subventricular zone, where the progenitor neuronal cell activity works, and there is a migration in a form of a very systemic process in the in the cues given by the chemicals produced by the notocard, and that process is so precise and selective that it brings in the more growth of precise pathways, connections of, and also in the later stage of the this phase in the fetal growth, there is the more volume of the brain in the form of sulci and gyri keeps growing, and the corpus callosum and the C-shaped formation of the diencephalic structures is a very important part of this, and we know that the neurovascular the formation growth is dependent on the growth of the cells, the territory, that territorial supply is based on the curvatures which the growing brain keeps taking. And we see the corpus callosum is very important because this is where the anterior circulation takes its shapes from the choroidal to the more human-like anterior cerebral and middle cerebral artery. So basically in the embryonic phase, it's the choroidal artery, which is the cephalic part of growing ICA, and this leads to the supply of the inner core, including the diencephalon and the medial hemisphere, growing medial hemisphere, and also the MCA territory later in the growth stage. So we see the different parts of the rostrum, geno, body, splenium of corpus callosum. We see the C-shaped corpus callosum is outermost present, and we see septum pellucidum, the radial migration cues are present here. The column of fornix, and these structures, mammillary bodies, column of fornix, again, fimbriae, they are also C-shaped, yellowish in this schematic diagram, and in the innermost we see the hippocampus, amygdala, and that blends into this inner core of the growing tissue. So the corpus callosum formation stage also shows the hippocampus, thalamus, and anterior commissure, and then fornix, hippocampus, thalamus, lamina terminalis, and anterior commissure. They grow to the next level of formation of third ventricular and peri-third ventricular structures. You see the septum pellucidum, fornix, and later on the human-like mesencephalic and more growth of telencephalon is visible. So this is the diagram which shows the very tiny 4-5 millimeter of embryo, and we see that there were the 6 arches. They are the pair of arches. Usually the fifth is absent. So the initial 2, they regress to form. The first one forms the mandibular arch, and the second one as the Hoyt artery. Mandibular artery is formed by the first, and we see many primitive vessels which regresses with the time, and we also see the process which started with the 2 dorsal aortas and 1 ventral aorta. The pair of dorsal aorta and ventral aorta, they are joined together in the process of growth in the embryo by the trigeminal artery, aortic artery, hypoglossal, and the cervical segmental proatlantal arteries at different stages of the growth. And we also see that the third aortic arch is going to be the ventral pharyngeal trunk. And we also see that these hide mandibular hide connections leads to the formation of the external carotid artery, and this internal carotid artery, which has different segments based on the component of origin from the first mandibular artery, first arch mandibular artery, second arch hyoid artery, and we see that from the distal third aortic arch, this hyoid, mandibular, and this primitive maxillary leads to the termination of ICA, the future ICA, which will keep on growing its lumen size, and you see the cranial division of primitive ICA and caudal division of primitive ICA. This cranial division is going to make the anterior choroidal and later on the lenticulostriate systems and the ACA MCA formation, and the caudal one becomes the posterior circulation, and the circulation from the beating heart in the embryonic period is from these aortic arches and the primitive ICA towards the brain, and this caudal division of the primitive ICA eventually makes a posterior communicating artery, and it supplies till the distal basilar, which is where the ICA arise from the basilar, and this is where the dorsal aorta they are formed. They are present here, and there are two longitudinal neural arches which combine together to they initially grow to form the vertebral artery, and the two vertebral arteries grow to form the basilar artery. And similarly, there are the segmental distribution of the primitive segmental C1 to C7. So the stage 1 clearly shows the distal primitive ICA bifurcation, as I mentioned. Cranial branch later on leads to the bifurcation in the form of cranial branch, and this distal primitive ICA divides into two. One is cranial, the other one is caudal branch. The cranial branch later on becomes the olfactory artery, primitive olfactory artery, and then the primitive olfactory artery changes its name to the anterior cerebral artery, ACA. And the caudal branch, it supplies a plexus at the mesencephalon level, and then it connects with the posterior communicating artery till the distal basilar distribution. A connection between the bilateral ICA posterior to the Rothke's pouch forms, and this early anastomosis of the circle of Willis has components of bilateral ventricular plexular longitudinal neural arteries from the cephalic part. They join together. They exhibit transient keratobasilar vertebrobasilar anastomosis, and as I mentioned, there are many connections right from the cranial, and some people also call posterior communicating artery as a channel, and the other channels are trigeminal, aortic, hypoglossal, and the atlantal one. So similarly, in the stage 2, when the embryo is a little more grown up, you see the more formation of this network in a more adult-like formation. You see the internal carotid artery, the proximal common carotid is visible arising from the third aortic arch. Basically makes the common carotid artery and the proximal ICA. And you also see the ventral pharyngeal trunk, the primitive mandibular height, and primitive maxillary artery is visible, and primitive dorsal ophthalmic artery is also seen. So the caudal branch of the ICA, extends posteriorly to fuse with the longitudinal. These are the longitudinal neural arches. They they eventually joins together to form the basilar artery. So that is why we see at times the duplication of the basilar arteries. If there is incomplete fusion of both longitudinal neural arches, it can lead to either the duplication of basilar or fenestrations, and we can, if we know the embryological way of fusion of vertebral artery longitudinal to longitudinal arches, then we can understand the dynamics of the vertebral artery and anatomical variations. The common origin of basilar perforators are extremely rare. Common origins from the basilar perforators has a different sort of there are symmetrical or asymmetrical basilar fusion process, and so far the flow is from the basilar side, and with the caudal primitive posterior communicating artery, this flow is from the third aortic arches, means the common carotid, internal carotid artery, and there are primitive ophthalmic arteries which later join together to form the different system which we call as hypoglossal stapedial system, which is formed by the hyoidomandibular and these primitive vessels. But here I would like to show that the longitudinal arches flow eventually combines together, and there is a hemodynamic stability of this flow at the level of ICA. So here you cannot differentiate the adult branches of basilar or carotid. So in the Paget stage 2, this is when we were talking about the formation of these neural arches combining to the basilar longitudinal neural arches, leading to the formation of the basilar system. And here we see that the third aortic arch and the fourth. The third becomes the proximal common carotid artery and then proximal ICA. So common carotid arise from the third and the proximal part of the ICA. And then this eventually we see the terminal ICA configuration and the posterior and anterior combining primitive arteries in the form of posterior communicating, trigeminal, olfactory, and this is how the flow compensate the growing needs of the embryo. Going to the formation of these major vessels and the thoracic vessels. So to reinforce one ventral and two dorsal aortas, dorsal aorta pair runs down posteriorly, and the first maxillomandibular and hide arches, which is second. These arches initially formed but are partially obliterated, and then there is the formation of this third and fourth arch, and usually we see the third, fourth, and the sixth as a very symmetrical paired arches. So here we see the regression of first primitive ICA formation at the initial stage, and later on we see the formation of internal carotid artery and the common carotid on the both sides. So the distal right dorsal aorta is regressed. On the right side it regresses. So you see the regression process, and you also see the distal portion of the ICA is derived from the cranial extension of the dorsal aorta. So here you see the dorsal aorta taking the shape of the distal ICA. The left aortic arch becomes the adult aortic arch. The left one, this you can see here, the third, fourth, fifth, and sixth. These are the aortic arches, and they are keeping their shape change with the growth. So you don't see aortic arch 1 and 2 at the stage of 11 mm. You see the third making the common carotid and proximal ICA, and you see the fourth and you see the subclavian artery from the seventh subclavian artery from the seventh aortic arch. You see the sixth one. You see the vertebral longitudinal connections combined together, and these intersegmental arteries makes the vertebral artery, and above the longitudinal neural arch forms the single basilar, and two vertebral arteries combine to form the posterior circulation. And in the later stages, the distal portion of the left sixth becomes the ductus arteriosus, and the left fourth aortic arch retains its connections in the fused dorsal aorta with a small segment of aortic sac. It becomes the aortic arch or arch of aorta. This is the arch of aorta. It has three components: the ascending, the transverse, and the descending. So you see the remainder of the descending aorta from the fourth thoracic level caudally is derived from the fused dorsal aorta. So the at dorsal aorta level, the two segmental C7 arteries make the left subclavian arteries. On the right side, you see the right vertebral artery and the left vertebral artery arising from the subclavian arteries at the 13 mm stage. And we see the arch of aorta formed, and this is the typical adult formation of three vessels arising from the horizontal part of the aortic arch, which is partly by the fourth aortic arch. And this is the configuration when the right common carotid arch uh, gives origin to the common carotid and the subclavian, and subclavian gives bilaterally this vertebral artery formation. So there are the 20% arch of aorta variations in the form of bovine arch, the 5 different vessels from the each arch, and it depends on the activity of how the external these aortic arches is regresses, and they combine to each other. And this represents the sketch showing the same process in the third stage of Paget, 33 days of embryo and around 12 millimeters, when we see the basic neurovascular components very visible, and we see the cranial nerves are also growing along with these neurovascular structures. So the segmental concept is that the neurovascular segment has its own nerve, its own artery, its own muscles, which we see growing along with the growth of the neurovascular. And in the next stage, we see the anterior cerebral arteries starts to take shape from the vascular plexus. More posteriorly, along the base of the hemisphere, there comes the primitive anterior choroidal. We saw that the anterior cerebral arteries are not the basic terminal ICA. So basically the primitive anterior choroidal artery gives the branches, and one of the initial branch which takes care, which runs within the cerebral hemispheres, is the anterior cerebral artery. And later the anterior cerebral artery gives further branches to the diencephalon and the groups of anterior perforators, including the recurrent artery of Hebner medial lateral lenticular striate. Striate forms the laterally projected ACA with a couple of striate coalescing over the telencephalon, which means the cerebral hemispheres growth leads to the primitive MCA formation. So when we see the variation in the MCA, it is based on the growth of the cerebral hemisphere in different lobes, which initially started from the insular surface, and we had the frontal, temporal, parietal, opercular growths, and this growth was coming from the neuronal subventricular zone progenitor cells, and then anything which can shape the lenticular or striate territory can lead to the different patterns of the middle cerebral artery. It can be 2 trunk or 3 trunks middle cerebral arteries. So similarly, proximally, the posterior choroidal artery is directed towards the diencephalon. So posteriorly, the posterior choroidal artery distally gives branches towards the mesencephalic, that means midbrain territory, and vertebral artery begins to form, and they unite to form the posterior carotid vertebro-basilar system with the anastomosis we discussed. And over the rhomboencephalon, the superior cerebellar artery begins to be seen. So it's the repetition of the same, in which we see the more anterior choroidals. The posterior communicating is now uh, more visible. Diencephalic territory has a branches towards that, and the growing diencephalic leads to the more recruitment of the more lumen, increasing lumen and increasing supply. We also see the many proximal dorsal ophthalmic systems at this stage. We see the mandibular and hyoid are growing at the proximal part to make more caudal approach towards the stapediohyoid system, and then the maxillomandibular system, which later on connects with the middle laryngeal system and leads to the formation of the more adult-like uh, ophthalmic supply, which is we see in the next. So here I have tried to show the diencephalic part, the five cavity formation. This is the initial simple plate leads to the curvatures, flexures, and you see a lot of diencephalic bumps and lumps here, which we see in the form of telencephalon at the caudal surface of the growing embryo, and myelencephalon at the spinal cord and brain stem junction. We also see the growing cerebellum, rhombocephalic stimulus, and also the different ventricular systems. Here, I would like to show you the diencephalic lamina terminalis, corpus striatum, hypothalamus, epithalamus, thalamus, and diencephalon. So, translating it to neurovascular bunch tree, this is little later when neurovascular processes are little more advanced. The height, the height of the fetus, the crown rump length is 20 to 24 millimeters at this stage. 45 days means it's the end of the embryonic phase. You see a very prominent middle cerebral artery and the anterior cerebral artery, and a common anterior choroidal artery, which was initially the source of MCA and ACA formation with the growing telencephalic activity. We also see the posterior choroidal artery, which we saw as the terminal posterior circulation of arised from the posterior communicating, which was joining the posterior communicating artery, which was joining the basilar and the internal carotid system. We see the mesencephalic supplies the diencephalic parts. It's not still completed. Superior cerebellar artery is more adult-like here. We see the ICA, so the flow in the posterior basilar system till the ICA, pica comes in between, and there are many patterns of the cervical segmental, proatlantal, the pica, and that reflects in the variation what we see in the normal situations in different individuals while we do DSA or see the vascular studies in MRA or CTAs. So the understanding them will become more important, predicting the many things like the branches, the safety zone for neurovascular intervention, that all can be very confidently predicted once we see how the embryological development gives the small branches and then making this tree growth into the adult-like structure. So we also can see here the common carotid artery and proximal ICA, and the ventral part, which we saw in the form of different primitive arteries. Now we see that the maxillary artery formation by here from the external carotid artery. This is the primitive external carotid artery formation. And this external maxillary artery then divides into infraorbital branch. And similarly, we see that the ophthalmic artery stem forms and takes over the previous primitive supply to the ophthalmic. So in the stage 7 of the Paget, a little later in the developing phase, we see the neck flexion status becoming more neutral or extensor like. With the growing brains and the weight of brain, we see the cleft taking the shape of the lips, mouth cavity, palate formation, and the defects of faciocranial happens at this stage, when these nasal pits, the orbital, the maxillomandibular regions, they grow further. We see the aortic arch, the ductus arteriosus, and we also see there are further differentiation of some of the primitive arteries, which we are going to discuss in the next few slides. So just let me know if I'm running out of time. So please, because this subject is too long, it's connected, there are repetitions, and we are chartering into an alien territory, which is not very used to for neurosurgeons. So we are trying to make things in the repetition form to understand, as I mentioned this previously. So the medial branch from the ICA form the plexus that eventually becomes the anterior communicating artery. So we already mentioned this primitive ophthalmic artery formation in the form of ventral and dorsal. Dorsal is the here we see the ventral primitive, and later anastomosis in the orbit near the optic nerve, with the new anastomosis forming the ophthalmic artery origin from the ICA. So the adult ophthalmic artery comes from the ICA, but initially the ophthalmic primitive comes from the maxillary formation, and from the ICA itself take over later on in the developing embryo. Commonly from the primitive dorsal ophthalmic artery goes on commonly from the inferolateral trunk, while the uh, primitive ventral ophthalmic artery becomes the A1 segment of the ACA. So the dorsal ophthalmic artery, uh, it makes the connection of commonly from the supply from the inferolateral trunk after making the connection, and the previous primitive ventral ophthalmic artery, it disconnects itself from the ophthalmic territory and becomes the A1 segment of anterior cerebral artery. So this is a lot of changes happens in the trunks and supplies and hemodynamics. So we see a lot of variations in ACOM configuration. We will see in the next lectures that there are at least 2 dozens of patterns of anterior communicating arteries. So that depicts how complex is the process of this taking over of different hemodynamical profusions, territories, and regression and annexations process. Increasing prominence of anterior choroidal artery, posterior choroidal artery, and mandibular artery as the basilar, and then the choroid plexus begins to form, and that supplies the anterior cerebral artery territory. So this is the territory which was previously anterior choroidal, then anteriorly and in the mid between the two hemispheres, the anterior cerebral artery that becomes more larger in size, and inferiorly it joins with the anterior choroidal, and posteriorly by the posterior choroidal, and this defining the choroid stage of Klosowski. And later this midbrain also gets some branches from this choroid stage. This was being described by the Raybaud, and these four branches forms the arterial feeders. And we will do the venous phase the next time. Here we see then MCA formed by the lenticular striate, as I showed in the cranial part of the growing fetus, where the middle cerebral artery territory was telencephalic growth, becoming more and more in the later stages of the embryonic period. And we also see that recurrent artery of Hubener joins that same territory, and it deploys the inner core of the insular region and the inner core. And there are PCA branches. So the choroidal system is the inner system which has a connection between the anterior choroidal, posterior choroidal, ACA, and we see different anastomosis patterns in the circle of Willis, which are not limited to the so-called the ideal formation of circle of Willis by the two ACA and two vertebral artery and PCOM and ACOM. So this is at a very bigger level from within the branches of ECA, ICA. Sometimes they are open, sometimes they open at the time of any need of blood supply. So that's one thing we have to learn. So the total persistence of a hydrostapedial artery. So as we multiple times saw that the ECA, external carotid artery system, terminated as a superficial temporal artery, the the deep temporal artery, medial deep temporal artery, the transverse facial artery. So there is a high stapedial system which arises from the intrapetrous ICA, and that course the middle ear and the middle cranial fossa, where it gives the middle meningeal artery before leaving the skull via the foramen spinosum to become the maxillary artery. This is what happens during the phase of the initial embryo, the ventral pharyngeal artery, which becomes the external carotid artery. So here we see the ventral pharyngeal artery combining the maxillomandibular division, means the first aortic arch and the Hyde branches. So the Hyde artery at its origin goes through the stapedial part, and then it divides terminally into two branches. One is one annexed with the maxillomandibular division of the maxillomandibular division, and the ventral branch makes the orbital branch terminally. And similarly, the Hyde distally, the posterior, this Hyde artery at this place distally also gives rise to the Vedian artery, and this changes into the two parts, the supraorbital division and the dorsal division. The dorsal branch later combines with the middle meningeal artery, and initial this flow model will become eventually connected. So the facial artery, external carotid artery, maxillary artery, these are visible as the branches of the external carotid artery. And we see the middle meningeal and orbital branch. We see the caroticotympanic, which is a permanent branch arising from the regression of stapedius. The Vedian artery also is visible here, and Vedian artery joins, we see the course of Vedian artery, which joins the internal maxillary and the internal carotid system. And the dorsal ophthalmic artery arises from the distal ICA, and it takes over the ophthalmological the orbital components. And this is important where the maxillary artery, orbital branches, and the middle meningeal arteries and median arteries, corticotympanic arteries, they all have a connection of flow. So the neuronal production in humans, so to summarize, begins on the embryonic day 42, migration to different brain areas. They begin to make appear in the early embryonic period, and it keeps on going in the middle to make connections with other neurons, establishing rudimentary neural networks. By the end of the prenatal period, major fiber pathways, including the thalamocortical pathway, are complete. So this is at the end of 7th to 8th embryonic week. The brain development continues for an extended period postnatally. The brain increases in the size by 4-fold during the preschool period. By the age of 6, it's 90% of adult, and the changes in the structural parallel, changes in the functional organization also reflect in behavior. The early postnatal period, the level of connectivity throughout the developing brain far exceeds that of the adults. So there is a lot of dynamic growth of the neurons. The developing brain of a uh, uh, fetus and postnatal is having a more dynamic and more profuse supply, and these exuberant connections is connectivity is gradually pruned back to normal adult-like, and there is a there is a well-documented plasticity and capacity for adaptation, and this is the hallmark of early brain development. And here we see the different segment origin of internal carotid artery in the form of the primitive aortic arch 3 making the common carotid, the carotid bulb, and the proximal ICA, the C1, the petrous ICA. So the normal development is from the third aortic arch. This one is the C2. So we see that the first, second, and third aortic arches, dorsal aorta and vertebral artery, then the dynamic processes leading to the different disconnections between the two, regression of first and second. The third makes the proximal ICA, and the key relationship contained within the carotid space, the posterior lateral, this ICA is posterior lateral to the external carotid, and anteromedial to the internal jugular vein, which I show you in the next diagram. And the normal variants are bifurcation. It is normally at the C4 vertebral level, this common carotid bifurcation. And the anomalies can be absence, hypoplasia, duplication, fenestration. Non-bifurcating carotid artery is less common, and the carotid basilar anastomosis in the form of primitive hypoglossal and intersegmental arteries at the atlantal level are more, more seen, but still very, very rare, one in 3 to 5,000 cases. So here we see the petrous part, the C2 segment of the ICA. We see that the posteriorly the internal jugular vein, the cranial branches are seen coming out from the hypoglossal. So we see the optic canal, second nerve, optic nerve. We see the vascularity of the ophthalmic artery supplied by the internal carotid branch, the dorsal ophthalmic artery. We see the supraorbital fissure and fourth, fifth cranial nerve, the first branch of fifth and fourth, and the third visible in the superior orbital fissure. We also see the V2 foramen of ovale V3, and this maxillary foramen is visible. The This is pterygopalatine fossa and internal maxillary artery. So the internal maxillary artery has a connection with the C2, the petrous part of the carotid artery, and this is what we call as the median artery. And this proximal part, this regresses, and initially the flow is like from the C2 to the maxillary artery, but later on this proximal connections regresses at the petroclival ligament level, and you find this internal maxillary branch flowing from the internal maxillary towards the intracranial cavity. So this is how the dynamic changes keeps happening, and here we see the adult posterior circulations where the two vertebral artery, anterior spinal artery arising from the vertebral, and these are the product of the cervical segmental arteries, C1 to C7, then basilar product of longitudinal neural arch. The fetal circulation comes here till the anterior cerebral anterior inferior cerebellar artery territory. So this is the superior cerebellar and posterior cerebral artery. We see the very complete circle of Willis with the two posterior communicating arteries, anterior communicating, and the MCA olfactory tract, optic chiasma, optic nerve. So when the growth trajectory takes the more blood supply, the luminal changes happens in the process of angiogenesis and vasculogenesis, and this leads to the size according to the territorial flow area. Here I would like to show you how this all embryological information tells us about the perforators, the patterns of the basilar branching, the vertebral arteries configuration, hypoplastic, aplastic, single. We can understand the fenestrations if there is. So here I would like to show you the basilar bifurcation. Actually, it's not the bifurcation, but it's the longitudinal arches fusion and P1 formation till the PCOM. So in the fetus, the flow is from the posterior communicating till this side, the distal basilar. So this part has a embryologically, the upper part of the basilar distal to the primitive trigeminal artery belongs to the caudal division of the primitive ICA. So that's what I mentioned in the flow, that the flow comes from the ICA till the distal basilar in the primitive age, and then in the fetal circulation, and then in the adult the more adult-like flow is seen. The basic direction of arterial blood of the BA basilar artery is cranial to the caudal at the beginning, but this reverses. And this change promotes the development of diencephalo-mesencephalic arteries. So if the symmetric basilar bifurcation, so the perforators usually arises from the mid. When it's asymmetric, but I mean at the same level, then we see that the distal closer to the neuronal tissue gives rise to the perforator branches. One pattern is also the artery of Percheron, which arises from the one proximal PCA, and it has a big trunk, and it supplies the bilateral diencephalic area. So this is the exception when the asymmetric basilar division. We know the symmetric has a midline, very organized sort of perforator pattern from the both tip and in the middle region, but in the asymmetric, the more distal part, like closer to the, like here, the closer to the diencephalonic structures gives rise to the perforators, and in artery of Percheron, the one of the PC.
It's incredible, friends. It's truly amazing.
So one of the artery of Percheron supplies both. So I think I stop here because these are the repetition of the same internal maxillary, the petrous branch, median artery, and middle meningeal. So we see the ophthalmic artery supply also. There are a lot of clinical correlations with, like in the cases of congenital hypoplasias. So any any territory uh, cannot exist without a blood supply. So that's what the Pierre Lesjonius gave in his famous teachings, that this sort of principles and rules to interpret different processes. Like if there is no, uh, at times when we don't see one ICA, it can be secondary change, the pathological change, or it's absent. How we come to know that the IC was not there right from the birth? So the congenital absence will lead to absence of the foraminal formation, because with the flow, the cranial cavity makes the foraminal entry of the extracranial vessels during the embryological developmental phase. So in this, we see the CT is showing the carotid canal on the left side, but on the right side, you won't see the lateral view is also showing the common carotid angiogram. So here you see the white arrow, which is showing that the left side MRI is more useful because it shows the flow signals, and the CT shows the canal. Naturally, it doesn't show the flow signals like the MRI shows. So having absence of foramen carotid canal in an angiogram where we don't see a ICA confirms that it's congenital hypoplasia, and this is how the embryology is relevant to the interpretation. So this is another important concept in continuity of what we saw in our earlier slides. So in the A, we see the hide artery. This is arising from the internal carotid artery. This is the aortic arch 1. So the stapedial artery arises from the hide artery near its origin. Sorry. So the stapedial artery and hide artery, they are, so the hide artery and stapedial artery are visible here. So this is the stapedial part. The stapedial artery branches into upper and lower division. The ventral pharyngeal artery are the precursors of the definitive external carotid artery. So this is the ventral pharyngeal artery. This is the precursor of the external carotid artery. And we see that in the growing fetus, this anastomosis forms between the hide stapedial branch, the lower division, and the ventral pharyngeal artery, and this makes the stapedial artery. With time, this stapedial artery, this is the stapedial artery. The flow becomes like from the stapedial hide system and the ventropharyngeal system. So this is what is in the initial phase. Later on, the stapedial arteries regresses in size, and in normal adult anatomy, this involution of stapedial artery is an adult pattern, and then these distal upper division makes the middle meningeal artery, and the external carotid artery is the future of what we saw here as ventral pharyngeal artery. So this ventral pharyngeal artery changes its name to the external carotid artery, and this gives rise, it's the biggest branch, which is internal maxillary, and has the most anastomosis with the internal carotid artery. So this is very important to know, because at times there is a persistent stapedial artery, and any surgery, any surgical approach will lead to the consequences. So the middle meningeal artery, yes, middle meningeal artery at times can supply the ophthalmic artery, and similar is the these remnants, these embryogenic carotid basilar vertebral anastomosis in the form of posterior communicating trigeminal, I would say trigeminal aortic hypoglossal proatlantal, because posterior communicating is more like an adult vessel, which may be hypoplastic, aplastic, but these trigeminal proatlantal, although they are rare, and aortic hypoglossal still very rare, one needs to know it when they are doing the neurovascular, endovascular decision making in individual patients. Thank you so much. And I stop here for any questions, comments, discussion. Thank you so much for your patience.
Very good. Thank you, Ada, for spending the time to put that together in a detailed discussion. And you know, when I took embryology in med school, I liked it. I didn't know why, but I liked it. But it looks like it's becoming useful for aspiring neurosurgeons to kind of have an idea of what's going on. Okay, the floor is open, and one of the benefits of having a live discussion is the ability to interact with Atta. Okay, Suresh, do you have a question or comment you'd like to say?
Yes. See, it's an excellent depiction of the embryology and particularly of the brain and the other parts also to some extent. And I'll tell you more about the vascular anatomy. As he has already commented, the areas where there are anastomosis with the external carotid circulation, and when there is a communication of the posterior circulation to the anterior circulation, these are the places where the variations take place maximally. That's what he told about the anterocoroidal, then leading on to the anterior cerebral and the middle cerebral. That's the area where the anterior communicating complex, there are lots of variations. That's why many times we see that the A1 is passing, it's very rare, but it's passing beneath the optic nerve. We see that during the operating on ACOM aneurysms. Usually it goes above the optic nerve, but sometimes it can go beneath also. So the embryological details we must be knowing at that time. That is one part. The other is that the petrous carotid, as he has already explained, that in the petrous carotid there is a lot of anastomosis between the external carotid circulation and the internal carotid circulation. That is why the endovascular people, many a times when they are embolizing the basilar meningiomas, they are very particular that when they are embolizing the external carotid circulation, their embolus may not enter, the embolizing material may not enter the internal carotid circulation. For that, they must be fully aware of the embryology of the petrous carotid and the anastomosis there. Similarly, say, if the till the mid-basilar, this is the posterior circulation which is taken care of, and from behind, anteriorly, it is the anterior circulation which is taken care of. That is why many times you see that this is the fetal type of PCOM. That's what exists. That's what is the other thing which one should know. Then, in the ophthalmic also, when you are doing some embolization procedures in the ophthalmic artery, you should be aware because there is a large part of the communication between the external carotid and the internal carotid circulation at the ophthalmic level. That's what is, and as he has already explained about the aortic, hypoglossal, trigeminal, these are really the critical areas of the anastomosis between the external and the internal carotid circulation, and one must be aware of when they are trying to do that.
Thank you. Yes, in the next sessions, we will also go into detail of these venous systems, the safety zone concept, where we are pretty sure that the perforators will not get involved when we inject in something for example, at a level of ophthalmic. Understanding the ophthalmic and other anastomosis capacities, anticipating it is important rather than going back and finding out that we did something which blocked the circulation at that territory. So it's being a neurosurgeon, I consider that when we are working under microscope, when we reach to the microscope with our experiences, with our temporary clips, we can assess the circulation, and we want before doing something big. But in catheter-based procedures, when we do that, that's more unforgiving. You need to have a very precise anticipation of what
Yes.
is going to be next. Otherwise, you do something, and after a delay of some seconds, you see on the monitor, and that's the stress level nobody can understand. And that's what makes the embryology necessary for us to keep on repeating, keep on teaching, keep on studying, keep on learning.
That's the reason that if you know the anastomosis between the external and the internal carotid circulation, and when you are embolizing the basal meningiomas,
Yeah,
then you have to be very specific that the particular area where the anastomotic channels are existing more at the petrous carotid level, then you may be bit, I'll say that you will be underplaying in embolizing those lesions at that stage. Because otherwise you may jeopardize the internal carotid circulation, which may be not forgiving.
exactly. And at
And
times,
yes, sir,
sorry,
please go ahead.
at times those visible connections, even in the angiography, till you knock out some feeders, you cannot see it because the hemodynamic demand uh, steal away the flow and redirect it to the tumor. And when the tumor supply gets decreased with the embolization, then the natural preserved roots, they come back to the hemodynamic flow. So even if you don't see, you anticipate. That's the message. Thank you.
Is it, Dr. Bhatti, is it possible by doing some procedure or maybe balloon occlusion or something like that, as we need to do to find out the circulation, say which is the augment, say the main circulation, like in the posterior cerebral, the anterior cerebral, this side or that side. Then is there something in these basal meningiomas also we can put some catheter and find out that are there any small connections there existing to the petrous carotid? Is it possible?
Exactly. This is possible. And this is where the hybrid neurosurgery plays its role. Because unlike to non-clinical people, we know what we are dealing. So coming back to your point, this was the basis. We have a very fine microcatheters. Now with the microcatheters balloons, so what we can do is we can do a two catheters or proximal block to create a condition to see the dominant flow from the other side. And now the catheter technology is very soft, very non-traumatic. In the days when it was in infancy, my mentor, Professor Valavanis, he depicted the watershed zones by the microcatheter.
Mhm.
So blocking the ACA like for 5 to 10 minutes makes the watershed shift visible. And as we know that the leptomeningeal collaterals are variable in individuals. So at times when you do this, this is like a classic balloon test occlusion. So if you uh, occlude the ACA, you see the MCA taking over through the leptomeningeal collaterals to the territory of ACA and vice versa. So yes, this is possible, and that's the whole point of doing operative DSA assessments. And it's not only now 4 vessel or 6 vessel. So it's super selective hunting of different vessels in the area of interest. So that's the gold standard. If we are dealing the base of skull, we want to explore that area. We have to go super selective to the microcatheters. And why the preoperative embolizations become best or worst is based on how near you were to the feeders. What was the number of feeders, and how good meticulous were your techniques. So it is possible
That's
to
true.
knock out all the tumor except the hairline profusions. So those are probably some of the tumor tiny vessels, and the others are the vessels which are the neoangiogenesis. So we have to be careful because there are a lot of sharing of normal and abnormal blood supply, especially this comes true from the extradural supplies like the meningeal dural recruitments. If the tumor is growing ever increasing way, it cannot find the supply from the main territory. It tries to sump in and make the new angiogenesis factors to make its supply from the other territories, from the external carotid, from the durals, from the leptomeningeals. And this is why the growth of the tumor can be assessed by the central necrotic portion. If the growth is too fast, even after this neoangiogenic process, you cannot fulfill the requirement of the inner core of the growing fast tumor. So in that, we see the inner necrotic core, the ischemic tissue of the tumor, and that itself, by and large, shows the high grade of tumors. It's a very interesting.
That's nice. Just one comment and one suggestion. The suggestion is that if you could transmit the references of your talk, that
Yes,
will be informative to everybody, and we'll be able to read the original article, and we'll be
yes,
more knowledgeable. That is one. And the another, say the request to Professor John Bennett that if you could transmit me the last talk, which I could not attend, that will be a great benefit to me. The
sure.
first I could, but the second one I could not. And the third is, as you have again and again emphasized, that the brain development takes place at the earliest of the embryonic age. That is why whenever you are advising any treatment to a lady who is pregnant, or you are doing any radiology in that patient, then you should see the last menstrual period and accordingly advise the medications and the radiology. Otherwise, that is the time the brain development has already started and you are jeopardizing the fetal. That's the thing. I think you had been again and again emphasizing on that. So whoever is attending the session, all neurosurgeons must be knowing that.
Yes, let me just clarify that my talk has references. I will specifically, I have shared some of the references, but the gold standard landmark article was Paget.
I know
And
that. I know that.
yes, and many of the studies later on, one of the uh, many references were taken from the Professor Kring, the Toronto General Hospital chief, Krings, and Lasjonias, Rodesh, and Valavanis. And these are the main themes which I am taking as a immediate
If,
trainee or Zurich School
if you
of.
can transmit it in the text, that will be useful. We'll go
Yes,
through those articles. It
I'll be
will be a
more
great
careful.
favor.
Yes,
Well,
yes.
you know, I put the link to the YouTube channel in, Suresh. You can get a copy of this webcast as well as all the past ones. And you'll get a notice when there's a future one. You'll get an email that Ata's going to speak on Saturday or whatever. And I don't know if you want to put a list of the references in the chat or you have time, but certainly, Suresh, if you leave your email address, I think can send you the sources.
I think I sent you the email address last time, and you sent me the link also about the next talk last time. Probably it is there as mathuri@gmail.com.
Okay.
And I'll send you again the email. Okay.
Okay, very good. Okay, Uday, do you have any comments? Uday is pretty active on social media. And I note that he is here. Are you here, Uday? Perhaps you may have, there you are. Okay.
Yes, sir. It was last time. It was very informative. This time also, and yeah, the clinical pearls were very informative, sir.
Okay.
Thank
Thank you. Thank you for participating, Uday. And Bernd Dobler, the co-chair of this organization, Neurocare for LMIC.org, I believe. Are you there, Bernd? You may have stepped away. Oh, there he is. Okay. Go ahead, Bernd.
Yes, I'm here.
Yeah, just please introduce yourself.
Yeah, I can just repeat what I said last time, that I'm a co-founder with Atta of our organization, and I'm interested in the neuroradiology part because I'm a neuroradiologist. So I think that's all I can.
You're into neuroradiology?
Yes.
Oh, okay, because we do have a webcast this Saturday from Spain on neuroradiology. And we have one, I don't know if you speak Spanish, but we have one in Spanish from Argentina on Wednesdays. Do you speak Spanish? No?
No.
Oh, okay. So I'll send you the link for the one on Saturday. I'll post
So
it
you
in
are
the
not a
chat.
neuroradiologist. You are not a
Yes.
neuroradiologist. You are an endovascular neurosurgeon.
There you go. Or
I'm a
dual.
neuroradiologist. I'm a diagnostic neuroradiologist, and I don't do endovascular things.
You don't do endovascular.
Yes.
Well, you know, I'm going to show, let me try to show you the webcast that we have coming up. Okay, this is the one now. Okay, here's one I'm really excited about, and I didn't know I was going to meet Atta, but as it turns out, he's a dual neurosurgeon. We're starting that this Sunday, and Otto, as you know, is a dual neurosurgeon, so this webcast is right up his alley. And we're going to collaborate with these gentlemen. I don't know if they want it, ladies and gentlemen, I don't know if they want to have it once a week or twice a week. But as you know, dual neurosurgery is a hot area now in neurosurgery. We're glad to be hosting that. So that's what we're looking forward to. Okay, Atta, thank you very much for spending the time and putting this together and organizing it. And we look forward to do you have any, now is this the fourth one? Is this the fourth one or the third embryology one?
Was the third one.
Okay, we have one more, right? We have one more.
And we had another one when we talked about our organization.
Okay, very good. Okay, same time, same channel. Hey, there's Fitri, you're quiet tonight.
Yes, John, I'm listening.
It's
good lecture. It's good lecture. Yeah, maybe it's like you always said that a simple, fast, simple, and preserve a normal anatomy. This is what maybe a lecture for it.
Well,
It's good lecture.
Yuha, because I spent 3 months with him in Nepal, he liked a video. He liked Google Hangout, which when it first came out, and he liked Zoom. And I'm sure you saw that. He would Zoom with anybody. I mean, any country. It didn't have to be a big academic Zoom. He would do it for anybody that wanted to do it. He was a very dedicated man, and we all miss him. So anyways, Atta, thank you very much, and we'll see you in 1 week and see everyone else. Thank you.
Thank you.
Bye-bye. Thank you for good lecture. Bye-bye.